Hello everyone, welcome to my YouTube channel, a dedicated platform for mastering clinical medicine. This channel provides in-depth, structured teaching on history taking, general physical examination, and all the systemic examinations, tailored for medical students, doctors, and healthcare professionals. The focus is on building strong clinical foundations, improving diagnostic skills, and developing a clear practical approach to patient evaluation. Join me as we simplify complex concepts and strengthen clinical excellence through detailed, exam oriented, and practice focused learning. With that said, let's jump to today's topic.
It is part one of the course named as Foundations of Clinical Assessment. This course gives you clear reasoning behind every step. You will learn exactly what to ask and what to observe and how to document efficiently so you can provide thorough, logical, and professional care from start up to finish. So, learning objectives of today's session are principles of effective clinical diagnosis, significance of history taking, and general approach to patient doctor interaction. Components of history taking, and underneath the components of history taking, we start with personal details, then chief complaints, then history of chief complaints or presenting illness. Then, underneath the history of presenting illness, we will learn how to describe pain, fever, vomiting, edema, cough, diarrhea, headache, joint pain, weight loss, convulsion or fits, paralysis or paresis, palpitation, chest pain due to MI, dyspnea means shortness of breath at rest, dyspnea on exertion, jaundice, dysphagia, and then we describe constipation. Then we focus on fourth component of history taking, that is systemic inquiry. Then we discuss past medical history and then drug history and drug allergy, family history, social history, personal history, and then finally ministerial history. When we completed our history, we need to engage the patient and share our information, and then all the components of the history taking are being combined together in form of a story, and we make a narrative documentation of our history. So let's now talk about principles of effective clinical diagnosis. For a perfect or correct diagnosis, a doctor has to follow three steps. Number one is history taking, that we will talk about this part in this lecture in detail. And then physical examination, general physical examination. The next topic of this course will be about general physical examination. And then finally, we jump to diagnostic investigations. Diagnostic investigations like lab tests and imaging modalities. Now, history taking and physical examination, either general or systemic examination, will lay foundations for forming differential diagnosis or provisional diagnosis. Differential diagnosis means the list of possible diagnoses. On the other hand, provisional diagnosis means most likely diagnosis. And at the end, when the labs and imaging modalities proves your provisional diagnosis, that becomes definitive diagnosis. So these three steps are very crucial for doctor to follow for correct and perfect diagnosis. Second thing is significance of history taking. Why are we taking history? First, that it is considered an art. It is an art of a doctor. Why? Because it is a combination and blend of empathy, intuition, and communication skills. Intuition means gut feeling, inner sense that something is wrong in this patient. However, he does not have any clear and obvious symptoms and signs, but something is wrong. This is how a doctor can analyze. And communication skills means the doctor should create a safe environment, a trustworthy atmosphere for the patient so that he has to open up and share all his secrets with you. And empathy, you have to be emotionally involved with the patient. You should try to understand and feel the discomfort of the patient. That's why it's considered an art. So when you have all these empathy, intuition, and good communication skills, then you will be able to identify pattern of illness, risk factors associated, and symptoms present in the patient. And After identifying all the risk factors, symptoms, and pattern, you will be able to make either differential diagnosis, means list of possible diagnosis, or provisional diagnosis, means most probably diagnosis. And then later on, with general and systemic examination and diagnostic investigations, you will be able to come up with a definitive diagnosis. Now, question is, how should be the interaction of a doctor with the patient? First, optimal positioning. Patient and doctor should be at the same level. There should not be any barrier between them, like desks or chair or any other things, and the place should be very, very comfortable. Then doctor has to introduce himself and as well as mention his position in the hospital. Like, my name is Dr. Ferali and I am working as a medical officer in this hospital, and I'm part of the team which are obliged to treat here. And then confirm patient's identity by verifying their names and date of birth. And the doctor can ask, would you mind if I know your name? And then he mentions his name and say, how old are you? So by these, you will confirm that you are examining the right patient. And then establish rapport, establish trust. And that is done with the mnemonic listen with care. L stands for listen actively and let the patient speak without interruption. So how can you put forward and how can you show the patient that you are listening actively and attentively? That is by nodding your head occasionally, lean forward and face the patient, eye contact, relaxed body and uncrossed arms, and give some facial expression. Then with the help of some verbal expression, like when the patient is talking and somewhere he stops, you can say, go on, it sounds difficult. So in between, put some commands of yours, short phrases of yours that you are really, really listening to the patient attentively. I stands for inquire with empathy. One is to feel empathy, another one is to show empathy. Inquire empathy means that the patient should realize that you are feeling his pain. So the patient perceives your kindness and feels comfortable. Like when he is describing his pain, you just can say, sounds very stressful. I can see you are in a lot of pain. And then S stands for show respect, polite language, and be mindful of their feelings. Try to call the patient with titles like Mr. and Miss. Anywhere, if you want to stop the patient, you just can say, excuse me, please, can you just come back to main topic? Or can you come back where we left the topic? So in this way, guide the patient with a very formal language and polite way. T stands for take your time. Do not rush. Allow them to share their story at their own pace. E stands for empathy. Like you have to feel empathy. Like put yourself in the patient's shoes and understand their perspective. Like how would you feel if you was having pain or if you had been that such a discomfort? So try to understand his position. Then navigate gently, guide conversation with patience and reassurance. Like don't say that, oh my god, I have 20 more patients to look at. So please hurry up and tell me what the hell is wrong with you, right? Never do it. Be patient and be gentle. And C stands for confidentiality. Make sure patient knows his information is private and you are not supposed to share the patient's personal information with anybody else. Then A stands for ask for permission before proceeding, means respect patient's autonomy, and it means taking informed consent. Explain what you are going to do in the history taking, or further on if you just want to perform the general or systemic examination. The patient has the full right to say yes or no. And E stands for effective questioning, open-ended questioning, not a yes-no question, so that you would be able to find out a descriptive image of the symptoms or signs. And always speak in easy and simple terminologies. Do not use difficult medical terms. So speak in the layman's language. This is time that we have to focus on components of history taking. The first one is personal details or biodata of patient. Take the name, age, gender, address, occupation, marital status, date of admission, and mode of admission. And you can narrate it in this way. For example, Mr. Ali or Mr. X, a 26 years old male, resident of Earth, working as a security guard, married, admitted on 16th May 2026. If this patient is referred from some other hospital, you can mention the name of hospital here. If not, then you after mentioning that admitted on 16 May 2026 by emergency mode of admission or outpatient department. So this is how you narrate the personal details or biodata of a patient. Then second comes presenting complaint or chief complaint. The reason for which patient lands in emergency or in outpatient department. List them in order of duration. The first symptom which appears the earliest should be mentioned first. Each complaint should be written in one line in patient own words. For example, fever for 6 days. You cannot say pyrexia for 6 days or cough for 4 days. So this is presenting complaint. Now, history of presenting complaint. It is a detailed explanation of chief complaints from the time they started up to the time of presentation. So we have to describe and explain the chief complaints and presenting complaints in detail. There is one confusing term for medical students, and I need to clarify this, that what is onset of illness? Onset of illness means appearance of symptoms after the disease process begins. Now, onset of disease can be either gradual or sudden. Gradual or insidious onset means that the symptoms develop slowly over days, weeks, and months. Patient cannot pinpoint the exact time. He does not really remember when did the symptoms appear. And symptoms are mild at the beginning and then slowly it deteriorates. And gradual onset of symptoms are mostly associated with chronic diseases like tuberculosis, hypertension. Then another one is sudden onset. If a disease or illness is having sudden onset of the disease, that is a medical emergency. For example, symptoms appear abruptly over minutes and hours, and patient can exactly pinpoint the exact time, and symptoms are severe and excruciating from the beginning, and it is associated with acute diseases. That's why there is a need of medical care, immediate medical care. For example, bowel obstruction, food poisoning, and acute pancreatitis. Let's now describe the most common presenting complaints. The first one that we need to describe is pain. If a patient presents with pain, then you have to ask about site of pain and ask the patient to point out the place. Now, abdomen is divided into 9 regions, and by finding the site of pain will tell you the cause of pain. For instance, if a patient is having pain in his right iliac fossa, it means it can most probably be because of appendicitis. And if there is pain in right upper quadrant, it can be because of cholecystitis or hepatitis. Then intensity of pain. Pain can be mild, moderate, and severe. You can ask the patient to score his pain from a score of 10, and while 8 to 10 being extremely excruciating pain. And pain which keeps the patient awake and tossed in bed is severe, like myocardial infarction pain, colicky pain, and pancreatitis. Radiation of pain. Pain which spreads from its main site while maintaining continuity with the main site, like myocardial infarction, where there is central pain, but this pain is also radiates to the neck, back, and left arm. Now, why radiation of pain is felt? Pain radiates due to shared pathways, and this confuses brain about pain's origin. Fourth is shift of pain. First, pain is felt at one site and relief from that and felt at any other site. Why patient is having shift of pain? Because original irritation affects different areas and brain perceives pain in a new location. For example, in case of cholecystitis, initially pain is at the right upper quadrant, and when inflammation spreads, it leads to shift of pain to shoulder and back. However, there can be mild discomfort at the right upper quadrant, but there will be very severe and unbearable pain at the shoulder and back. Kidney stone. As the stone moves down the urinary system, pain shifts too. Fifth that you have to ask is about referred pain. Pain felt away from main site due to common nerve supply. For example, epigastric pain in inferior wall MI. Then you need to ask about duration of pain, duration pain-free interval, and frequency of bouts of pain. You can ask in this way, okay, excuse me, how long have you been experiencing the pain? Does it come and go or is it constant? Then try to know the periodicity of pain. Pain which follows a regular pattern or cycle like menstrual cramp pain, migraine, and tension headache. Then character of pain. Character of pain can be crushing and squeezing type, that's called heaviness, burning type, or aching. Aching is called dull, mild, and persistent pain like back pain, any kind of muscular pain, or toothache. Stabbing pain is deep, sharp, and short-lived. And to know that jolt-like, which is also electric-like, that is also deep, sharp, and short-lived, but jolt-like is shorter than pricking pain. You feel the stabbing pain when you hit your elbow against something and there is a radiation of pain along the course of ulnar nerve. Pricking pain is superficial, sharp, and short-lived. For example, carpal tunnel syndrome, diabetic neuropathy. Jolt-like, as we already described, it is electric type pain and it is a deep, sharp, and shorter lived than the stabbing pain. For example, trigeminal neuralgia. Throbbing is flushing type pain and it is typically found in migraine. Gripping pain is tight squeeze like cramp pain. Colicky pain, it arises from hollow organs like intestine and it alternates with pain-free intervals. Then ask about a special time of occurrence like duodenal or peptic ulcer. Peptic ulcer pain starts immediately after ingestion of food when there is a release of acid. And duodenal ulcer pain starts hours after ingestion of food when there is gastric emptying or angina pectoris, which is being initiated with stress, extreme cold, or exertion like climbing upstairs. Then ask about aggravating factors. You can ask it in this way: Sir, do you notice anything that seems to make your pain worsen, like movement, exertion, tea, spicy food, breathing, or coughing? And then ask about the relieving factors. Like, is there anything that helps to alleviate or improve your symptoms, like rest, food, or medicine? Then ask about associated factors. Like, in addition to the pain, do you have any other symptoms like vomiting, headache, hematuria, palpitations, sweating, and so many other things that you can relate to the main presenting complaint? Progression. When the pain started, how did it continue? Like, did it increase or decrease or stay the same? So it was how you can describe pain. Like summary of describing pain is given in this picture. Then let's now describe fever. In a medical term, we call it pyrexia. And you can remember the points with the glow tab. Before discussing fever or pyrexia, let's know some basic things like normal body temperature is from 98 to 98.6 Fahrenheit or 36.6 to 37 centigrade. And temperature above 98.6 Fahrenheit or above 37 Celsius is called pyrexia or fever. But if the body temperature is more than 107 Fahrenheit or 41.6 Celsius, then this is called hyperpyrexia. Now, hyperpyrexia leads to dehydration, denaturation of enzymes, which leads to rhabdomyolysis, means breakdown of muscles, which leads to kidney damage, electrolytes imbalance. Now, if the body temperature is below 35 Celsius or below 95 Fahrenheit, then it's called hypothermia. Now let's explore the GLOR tab. G stands for grade and fever has two grades. Low grade, it means when the body temperature is below 101 Fahrenheit or below 38.5 Celsius and it occurs due to chronic infection. High grade when the body temperature is above 102 Fahrenheit or above 39 Celsius and it occurs because of acute infection. L stands for either the fever is localized or generalized. O stands for onset. It can be sudden onset or gradual onset. We have discussed about it. Then fever is either associated with rigor or chills. Chills mean mild shivering and skin is cold and this mild shivering raises the body temperature. When the body temperature is raised, it is being followed with by sweating, which is called defervescence. Rigor is violent shivering, and this violent shivering extremely rises the body temperature within a very short time. However, when shivering occurs, skin is cold, and when the body temperature is raised, it is being followed by sweating, or also called defervescence. Now remember, the sweating does not occur if patient is dehydrated, and normally before this that the medicine has to kick in, we ask the staff or nurse to do tepid sponging of patient to give the patient rapid comfort. In GLORTAP, P stands for pattern of fever. Fever can be continuous, remittent, and intermittent. Continuous means doesn't that the fever or body temperature doesn't touch the baseline, and daily variation is less than 1 Celsius. Daily variation means the difference between highest temperature of the body recorded and lowest temperature recorded. Example is typhoid fever, where there is a step ladder pattern, and remittent fever when the body temperature doesn't touch the baseline but daily variation is more than 2 Celsius, and it occurs in leptospirosis and dengue fever. Intermittent fever is a fever which is being followed by fever-free intervals within 24 hours, like malaria, relapsing fever caused by spirochetes, and spirochete is caused by Borrelia burgdorferi. Now jump on types of fever like quotidian, tertian, quartan, relapsing. Quotidian, it happens daily and is caused by Plasmodium falciparum. Tertian, it happens after every 48 hours, means after every 2 days, and is caused by Plasmodium ovale and Plasmodium vivax. Quartan fever, it happens every 72 hours, means after every 3 days, and is caused by Plasmodium malaris. And then relapsing fever, that is, fever occurs for some days and then there will be fever-free days, like pale abstent fever, which occurs in Hodgkin lymphoma and spirochete. And again, I told you spirochete is caused by Borrelia burgdorferi. Then associated symptoms. If fever occurs with rash, this is called exanthematous fever. And this exanthematous fever occurs in rubella, measles, and chickenpox. The summary of description of fever is being shown in this picture. Now let's describe vomiting, or emesis. In medical term, it is called emesis. Describe about the duration, frequency, relation with food intake, any special time of occurrence of vomiting. If the vomiting is chronic, means occurring for a long time, is it being associated with weight loss? Then quantity of vomitus, color and smell of vomitus. If blood is in the vomitus, if blood is present in a vomitus, we call it hematemesis. And in case of hematemesis, then you have to further ask some questions like about the color of blood, quantity of blood, frequency of hematemesis, and association with melena. Melena is a dark colored stool and it occurs because of upper or lower GI bleed. Summary of description of vomiting is shown in the picture. Then now let's describe edema. In case of describing edema, ask about the site of edema. Either it is generalized, that occurs in nephrotic syndrome, and it is also called anecerca. Either it is localized, like pedal edema, that occurs in congestive cardiac failure. Then ask, where did it start first? Like if it is started around the eyes, then it is indicative of renal disease, and if it is started below the waist, means it had started as a pedal edema, then it can be because of heart failure. Then is it being having any association with breathlessness, anorexia, vomiting, oliguria, malabsorption, abdominal distension, which may occur because of cirrhosis? Summary of describing edema is shown in this picture. Then describe cough. Ask about duration, frequency. Is it more at night, morning, or evening? Is it dry or productive? And if it is productive, then ask about the quantity, smell, and color of sputum. Now, white colored sputum shows that there is no inflammation. But if there is green or yellow colored sputum, then it shows that there is inflammation, and inflammation can be because of infection. Then ask about that, is sputum more at morning or not? Is blood in the sputum, and blood in sputum or coughing blood is called hemoptysis. And then ask about the frequency of hemoptysis, quantity of blood in sputum. Do you see any pure blood? If you see pure blood in sputum, this is called frank hemoptysis, and it occurs because of lung cancer, tuberculosis, and bronchiectasis. And then ask either sputum is mixed with blood, which may show that the blood is coming from the lower respiratory tract. Summary of describing cough is being shown in this picture. Then describe diarrhea. Ask about the duration, frequency, quantity of stool. For example, if the stool is small, bulky, and difficult to flush, can be because of malabsorption of fat, and that's called steatorrhea. And then consistency of stool. You can show Bristol stool chart to the patient and ask the patient to pinpoint the consistency of his or her diarrhea. Then I ask either the stool is having mucus or blood with it. Now, acute diarrhea with blood can be caused by dysentery, or if there is chronic diarrhea, means a diarrhea which lasts more than 2 weeks and having blood in it, it can be because of ulcerative colitis. Then ask with either the patient has tenesmus, means sense of incomplete evacuation. Then ask either it occurs at night or not. Now, nocturnal diarrhea may occur because of organic diseases of gut, like may have some structural or pathological changes in the gut. Then ask either the diarrhea is having any relation with food. If diarrhea occurs right after food intake, it can be because of gastrocolic reflex, dumping syndrome, and irritable bowel syndrome, or maybe food intolerance like lactose intolerance. If the interval between food intake and onset of diarrhea is delayed, it can be indicative of infection or can be indicative of foodborne illness or parasite infection. So a summary of the diarrhea is being shown in this picture. Then describe headache. First, site of pain. For example, in case of psychogenic headache, the pain is felt over the vertex, and in case of organic cause of headache, the pain is felt at frontal or occipital part of your scalp. Then ask about intensity of pain, duration, character, any special time of occurrence. For example, cluster headache occurs at night, and headache because of sinusitis occurs after sunrise, means occurs at morning. Any aggravating and relieving factors, any associated phenomena like halo appearance around the lights, flashes of light, or rhinorrhea, which can occur before migraine, or associated with insomnia, anxiety, or depression. And then ask about effect of painkillers, means effect of analgesics. Psychogenic headache, which is because of depressive disorder, does not relieve by analgesics. So here you go. There is a brief summary of describing headache. Then describing joint pain. Ask the age of onset and then which joint was first involved. What was the sequence of involvement of other joints? Like, did it start from small joints and now it has involved the larger joints, or no, it started with the larger joints and then now involving the smaller joints? And now, did pain in the previously involved joints persist or disappeared when other joints were affected? To rule out migratory arthritis, which occurs in rheumatic fever, rheumatoid arthritis, lupus arthritis, and Lyme disease. Then relation of pain with movement. Do you see any morning stiffness, or if there is a stiffness, for how long the stiffness persists? Past history of trauma to rule out osteoarthritis, any systemic illness associated, and like bowel, urinary, or eye problems. And then see for cardinal signs of inflammation. Cardinal signs of inflammation like pain, redness, immobility, swelling, or heat. Summary of the describing joint pain is shown in this picture. Then describing weight loss. How much weight is lost? You can make some estimation if the exact weight loss is not known. And how is the appetite? If the weight loss is here despite good appetite, then ask about the symptoms of hyperthyroidism or diabetes mellitus. Or weight loss is there with decreased appetite, then rule out any chronic infection or malignancy. Then describing convulsion or fits. Ask about age of onset. Did it occur during sleep or awake? And then shortest and longest interval between attacks. Then association with fever like febrile seizure occurs in children, or any other symptoms like vomiting, sensory or motor symptoms. Then information about occurrence of the attack. You can remember it by mnemonic. All lazy residents take good training during tough posting. R stands for aura, L stands for loss of consciousness, R stands for rigidity, T stands for tonic clonic or tonic clonic types. Good stands for generalized or localized. Training stands for tongue bite, urinary or fecal incontinence during attack. During stands for duration of attack. Tough stands for fall or trauma. And posting stands for post-ictal symptoms like sleep, headache, paralysis, irritation. Let's discuss describing paralysis or paresis. Ask about which part is involved. Either it is monoplegia, means only one extremity or one limb is involved. Paraplegia means both lower extremities are involved, or hemiplegia means half of the body is involved. Then ask either the weakness is complete, which is called paralysis, or partial, which is called paresis. Is the weakness static or progressive, means the weakness has stayed the same, or no, it has just deteriorated. Is speech or other cranial nerve affected, like sensory or visual symptoms? How was the onset? Was it sudden onset or gradual onset? Looking for stroke risk factors like modifiable or non modifiable risk factors. Modifiable risk factors are like obesity or smoking, non modifiable risk factors are diabetes or hypertension. We will talk about stroke in our coming lectures. Past history of similar event or what was the outcome. Then early warning signs. We can remember the early warning signs of stroke by mnemonic E-FAST. E stands for eye, means any visual impairment. F stands for face drooping. A stands for arm weakness. S stands for speech difficulty. And T stands for time to call emergency, because it is a medical emergency. Then describing palpitation. Palpitation means awareness of heartbeat. Ask either it occurs at rest or on exertion. Ask about the duration of attack. Does it start and end gradually or suddenly? And then association with breathlessness, chest pain, sweating, weight loss, and heat intolerance. Now describing chest pain due to myocardial infarction. The mnemonic is OPQRST. O stands for onset and what was the patient doing when it started. P stands for provocation and palliation. Provocation means what brings the pain, like exertion, stress, cold weather, heavy meal, anemia, tachycardia, or sexual activity. And what relieves the pain, like rest or glyceryl trinitrate. Then quality of pain, it can be pressure like crushing or heaviness. Then ask about region. In case of myocardial infarction, the pain is central and retroesternal. Then radiation to left arm, jaw, neck, back, and epigastrium. Any associated symptoms like sweating, nausea, and vomiting, and ask about the severity of pain, and then duration of pain, and ask about any progression. The summary of the describing chest pain due to myocardial infarction is shown in this picture. Describing dyspnea means shortness of breath at rest. It can be because of asthma. So if you suspect asthma in patient, then ask about age of onset, any wheeze. Now the difference between wheeze and rhonchi. Wheeze is audible with naked ears, and rhonchi can only be heard on auscultation. Then frequency and severity of attacks, duration of attacks, and family history of asthma or other allergies, or either patient is having skin or nasal allergies. This patient needs regular treatment for controlling asthma. And summary of shortness of breath due to asthma is shown in this picture. Then describe asthma on exertion. Ask about the duration and progression, then how much exertion precipitates dyspnea, like climbing, running, walking at normal pace, at how much distance dyspnea will occur. Then history of paroxysmal nocturnal dyspnea means patient wakes up due to shortness of breath at night. And then ask about orthopnea, means patient has shortness of breath on lying straight. And causes can be remembered with HOPHOT, that is heart failure, which causes pulmonary edema, obesity, which stresses the lungs, pulmonary causes like COPD and pulmonary hypertension, pleural effusion, obstructive sleep apnea, and diaphragmatic weakness. Then dyspnea associated with any other symptoms like cough, sputum, palpitation, sweating, chest pain. And then past history of chest pain, hypertension, fever with joint pain due to rheumatic fever causing rheumatic heart disease. Now, if patient presents with jaundice, you can rule out the causes of jaundice with your history. Like pre-hepatic causes of jaundice can be ruled out by asking about patient's urine and history of itching and color of stool. If patient has pale urine but no history of itching and color of stool is dark, then jaundice has prehepatic cause. But if patient has mild but or no itching and the urine is dark and the stool is either normal or pale in color, then cause of jaundice can be hepatic. But if patient has pale or clay colored stool with dark urine and extreme itching, then it can be because of post-hepatic cause of jaundice. Now, itching occurs because when the bile salts leak into bloodstream, and dark urine is because of conjugated bilirubin, and pale colored stool occurs when no bile enters the intestine. Ask about right upper quadrant pain, which can occur in case of hepatitis and cholecystitis. Ask about color of stool and urine. Loss of appetite may be associated with hepatocellular carcinoma. Any history of itching, any history of contact with jaundice patient, history of blood transfusion or IV injection or hepatitis B or C, and distaste for smoking, which is very common in smoker patient when having hepatitis. Now, describing dysphagia means difficulty swallowing. Ask about duration. Ask either it is progressive or constant. Ask either dysphagia is too solid, liquid, or both. Now, liquid needs more coordinated contractions at faster pace, and solid needs less coordinated contractions and needs sustained contraction. So, on the basis of these two information, we can come to know that nerve and muscle impairment causes dysphagia to liquid first and solid second. But mechanical obstruction like narrowing of the esophagus can cause dysphagia to the solid first and then liquid. Ask either the swallowing is painful, which is called odynophagia, any history of GERD, or any history of weight loss. Now, causes of dysphagia to liquid more than solid, like myasthenia gravis, bulbar palsy or pseudobulbar palsy, stroke, motor neuron disease, Parkinson disease, or oropharyngeal dysphagia. Or difficulty swallowing solids more than liquids, the causes can be esophageal carcinoma, esophageal structure like peptic, corrosive, or post-radiation, esophageal web like Plummer-Vinson syndrome, Skatsky ring, or foreign body impaction, or benign esophageal tumors like leiomyoma, or causes of difficulty swallowing liquids more and solids both. In achalasia and diffuse esophageal spasm, there will be difficulty in swallowing both liquid and solid. Now, describing constipation. The mnemonic is constipate. C stands for consistency. We can find it out from the Bristol stool chart, as I had shown you earlier. O stands for onset and duration. N stands for number and frequency. S stands for need of straining while defecation. T stands for any trigger like stress, opioids, anticholinergics. I stands for any investigations done before, like colonoscopy or labs. P stands for pain, like abdominal pain, painful defecation. A stands for any alarming signs, like hematochezia, means blood in stool. Melena means dark colored stool because of GI bleed, weight loss, or anemia. Then T stands for try treatment, like enemas, laxative, lifestyle modifications had been done for treating constipation. Then end complications, like complications which is being associated with constipation, like hemorrhoids, anal fissure, rectal prolapse, or dependence on laxatives. Of constipation being shown in these beautiful pictures. Some examples of chief complaints or presenting complaints description. Now let's jump into systemic inquiry. Systemic inquiry is done to uncover hidden symptoms or associated symptoms which are considered unimportant or unrelated to presenting illness. For narration, if no positive findings are found, then write each system as such. For example, patient denies change in weight, energy, appetite, sleep. Dermatological review is negative for rush, itch, colored spots, or cardiovascular system review is negative for breathlessness, palpitation, chest pain, feet, edema, or respiratory system review is negative for cough, sputum, and hemoptysis. You can continue in such a way if it was needed, if the examiner allows you to continue it. However, generally we don't mention it. We just say that the systemic inquiry is negative for central nervous system, genitointestinal system, urinary system, nervous system, and blah 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 things. Component of history taking is past medical history, and you can remember it with MJ threads cup. M stands for myocardial infarction, J for jaundice, T for tuberculosis, H for hypertension, R for rheumatic fever, E stands for epilepsy, A for asthma, D for diabetes, S for stroke, and K for cancer. So you need to ask about all the diseases so that to make sure patient is not forgetting any complication or any disease he had before in his life. Write the medical conditions with the duration and treatment. For example, if patient is already having hypertension, so you can write down that hypertensive for 15 years and it's being controlled with the tablet captopril 25 milligram taken daily. Sixth component is drug history. Ask about all medication that patient is currently taking, how much they take, how often they take it, and how they take it, means route of administration. If they take it regularly or not, means does the patient have compliance with drug taking, and ask about the recreational drug or over-the-counter medication. Then seventh component of history taking is drug allergy. If patient has allergy to any medication, then ask what reaction they had. Eighth component of history taking is family history. Doctor can find out potential genetic predisposition and tailor the preventive measures and treatment plans accordingly if there is any family history for any genetic disorder. Ninth component is social history. Ask about occupation, marital status, tobacco use. If patient is a smoker, then calculate pack year. Or if the patient is alcoholic or not. If the patient is alcoholic, then ask about number of units patient consumes per week. Any illegal drugs, ask about if the patient is child, then ask about the immunization history, home surrounding, travel history, and inquire about any pet at home. Tenth component of the history taking is personal history, like socioeconomics, nature of family relationship, spatial worry, dietary details, and sleep disturbances. If patient is female, then take menstrual history, and we have mnemonic menstruates. M stands for menarche, so ask about age of menarche. E stands for expected date of menses, or what was the first day of last menstrual period. Then number of days means duration of flow. S stands for size, means amount of the blood loss. T stands for time interval between two menses, means that you can find out the cycle length. Then R stands for regularity, means either the cycle is regular or irregular. Did she have any missed periods in the past few months? And then unusual symptoms like dysmenorrhea, premenstrual dysphoric syndrome. A stands for associated complaints like menorrhagia, metrorrhagia, oligomenorrhea, or polymenorrhea, presence of blood clot, and frequency of change of tampons and pads. E stands for effect on daily life like school and work, absenteeism, bedridden due to pain or dysmenorrhea, and need of analgesics. And S stands for sexual activity, means there is pain during intercourse, menopause status if the female's age is above 45 years, and use of any contraceptive. So we learned all 11 components of history taking. Now, imagine that you have taken a thorough history, made a management plan. So, you need to engage the patient and share your management plan with your patient, like need of general and systemic examination or some required investigations, which can be lab tests or imaging modalities. For definitive management, you opt to one of the following or multiple of the following, like conservative management, medical management, surgical management, interventional management, or supportive or palliative management. So, at the end of your history taking, everything should be clear for you and as well as your for patient that what steps you are gonna take future in the course of treatment. So here I added a narrative documentation of history taking because you need a clear, continuous, and professional written record of patient history rather than short bullet points. Well, thank you for staying with me through this session. Don't forget to watch the other videos in this course to complete the topic. Please subscribe, share, and if you need a written note of these all lectures, you can join my WhatsApp community. Thank you very much.